Thank you so much for that, Dr. Staudinger. Um, like you just rightfully said, a lot of this was based on research and work that I was doing while back home in Cameroon, which is also where the name of the foundation came from. My late sister, her middle name is B and mine is Free. So when you put it together, you get your healthcare should be free, which is what we're all striving for to get people to get screened and get people to get treated for things like malaria. So with that, I'll go ahead and get started. Thank you so much for this opportunity. Thank you for those that were able to make it and for those that'll be watching in the future. This presentation is based on the diagnosis of malaria, and it's a case report. The title is The Diagnosis of Malaria in Non-Endemic Areas, Giemsa-Stained thick and thin blood smear versus rapid diagnosis test. And we're going to get into what all of this means very shortly. I would like to thank my faculty advisors, Dr. Adefuye and Dr. Martin, who helped me begin to gather my thoughts and get this to make sense. So, just a brief little roadmap. Everything is always nice to have a roadmap so we can know where we're going. So, for the agenda today, we're going to have a little introduction, the what and why of why we're even doing this talk. We're going to talk a little bit about the epidemiology of malaria. We're going to go into the case report itself. Then we're going to talk a little bit about the proper malaria diagnosis. And then we're going to end with a discussion into why this is so important and why I felt the need to share this with the rest of my student colleagues. And then we're going to end it with the closing remarks and any questions that I may be able to answer. So, what is malaria? Hopefully, we all know that malaria is a disease that's caused by a plasmodium parasite, which is spread through the transfer of infected mosquitoes. Directly, how it's spread is through the saliva of the mosquitoes. So, as you can see here in my illustration, when it bites you and it injects into your skin, that's when they start spreading the parasites. And based on the stages of the ova and the larvae, that's when you'll get your disease presentation. And they replicate mainly in your erythrocytes, your red blood cells. So that's why you see the systemic infections the way that we do. So, a little bit about these words non endemic versus endemic. What are these and why are they important? So, according to the CDC, that's the Center for Disease Control, malaria should be considered a potential medical emergency and it should also be treated as such, especially in non-endemic areas where the prevalence and knowledge of the disease are lower. So what do I mean by non-endemic area? So an endemic malaria area would be areas in which the transmission and the rate are highest. And a non-endemic area would be the complete opposite, where the rates of transmission are not that high. So the knowledge of the diagnosis and the disease presentation might not be the greatest. And so that's where you would call it an endemic disease in those areas. So, malaria's worldwide impact. In 2020, there was an estimated 627,000 people that died of malaria, and majority of these people were children in the sub-Saharan African region, and that's kind of a pretty big number, especially considering it's a disease that has a cure, it has a treatment, and there has various ways to diagnose it. So why is exactly so many people dying of these disease, especially children? The CDC and the World Health Organization have been doing many interventions in order to save the lives of millions globally and cut the mortality of malaria down, which we have been seeing. And the hopes of this is to not only control the spread of malaria, but ultimately eliminate the amount of mortality cases that we see. The areas that have the highest amount of malaria deaths are Nigeria being number one, the Democratic Republic of Congo, Uganda third, and Mozambique fourth. Nigeria being number one is very important in this case specifically because you're going to see how that played a role in our patient presentation. Reducing the impact. So, how can we as healthcare providers reduce the impact and the mortality of malaria? The number one crucial thing is proper diagnosis and treatment. A disease that has a treatment, the only way people will suffer mortality from it is if it's not diagnosed in a timely fashion and if it's not treated properly. And that's our job as healthcare professionals to make sure that we're doing this. The next big thing is the National Malaria Control Program, which is aiming to reduce the number of malaria related cases and deaths. In 2021, the World Health Organization, that's the WHO, they recommended a broad use of a malaria vaccine. And in 2023, actually October of this year, so a little less than 2 months ago, they recommended another safe, effective malaria vaccine that they intend to be used on children that are in these very endemic areas. So a little bit about the epidemiology of malaria, the what, high, when's, where, and why are we even talking about this? According to the World Malaria Report, in 2021, there was about 244 million cases with 610,000 deaths. In 2022, there was about 249 million cases, so 5 million more. But as you can see, the number of deaths did decrease. So there are more cases, but there are less deaths. So we're going to talk into a little bit about why there might be a spike in cases and a decline in deaths. The diaspora, for those who do not know what diaspora is, those are people that came from a region and migrated to something else. So you can have your African Americans that their homeland is in Africa. You can have your Asian Americans that their homeland is in Asia, but they're living in the United States. When they travel back to their homeland where there's a malaria endemic area, you have more traveling of people that are going into these malaria endemic areas, but they're based in non-endemic malaria areas. So that could be another reason why we're seeing a spike in cases because more people from the di- diaspora are traveling back to their homelands. There's also a big part of the economical impact on migration. A lot of people are moving to America and Western parts of the world in order to find financial freedom, whether it's from wars and political asylum or just various reasons. But you have people that are migrating from endemic malaria areas to non endemic malaria areas. A little bit about the diagnosis of malaria. The bread and butter of this is that early and accurate parasite diagnosis is crucial and evident to effectively manage and control the disease progression. It's almost like the flu. When you have the flu, you have about 72 hours to take the flu medication. After that window, it's not that the medication won't work, but you're less effective. Same thing here. So, your gold standard way of diagnosing is a blood smear. The Giemsa-Stained thick and thin blood smear that you smear, you take the blood, you stain it, you look at it under the microscope, and you actually look and see the stages of the parasite and how many there are there. And that's also how we were diagnosing it in Cameroon. We literally had counters, you're looking at it under the microscope, and you take the person's body weight in kilos and you kind of do a little bit of math to see how much of the parasite burden can be in the entire body. You also have PCR testing that's very effective as well, but all of us that are in the medical field kind of know that PCR testing takes a little bit long to get, and you don't want these people sick for days waiting for these PCR tests to come back, which also ties in the fact of medical technology is also very important. It is getting kind of obsolete to a certain extent now with a lot of our information and technology, but this should hopefully hone in the importance of having those microscopic skills. The test that's used the most in malaria endemic areas is the RDTs, the rapid detection test. I've personally had malaria a few times when I was in Cameroon. It walk like a duck, quack like a duck. They're so used to treating it. They just gave my finger a little prick, dropped it on that, and it was positive. Now, I've also had malaria before, so I did already probably have some of the antigens that were able to show a positive on this. And we'll get into a little bit later why this is so crucial in the timing and when you administer this test. So the clinical picture, what does malaria look like when you see someone that presents with malaria? So malaria can be suspected based on patient's travel history, if you know that they went to a malaria endemic area, based on clinical symptoms like flu-like symptoms and physical findings on examination, or they have arthralgia, is there weakness, those kind of things like that. It's also good to keep in mind as clinicians that there is an incubation period. So, for example, if I traveled to India and I didn't take any chemical prophylaxis, I didn't use any malaria anti nets or anything like that, I'm not going to present sick the very first day that I come back. I might get sick like 7 days after, up to a month after, depending on the type of plasmodium that infected me. So, that's also something to keep in mind as well. The most typical symptoms that we'll usually see are fever, chills, sweats, headache, nausea, vomiting, body aches, its nature.
Some hair on your
Okay, there's an echo. So, going into the case presentation, the basis of this case presentation is to highlight a scenario in which a non endemic area used an RDT and not the gold standard of the thick and thin blood smear staining to diagnose a patient, and it didn't really go too well. So, the whole point of this is to just preach the importance of knowing how the disease presents, when it presents, and most importantly, knowing when to use the proper diagnosis tools so you don't get false positives and false negatives and things of that nature. So, case report. The case happened in Johannesburg, South Africa. And if you can look at my little mouse here, the arrow is pointing to the star. This is the region in which South Africa is. And as you can tell based on the yellow, malaria is not really transmitted that much in this area as compared to the rest of the sub-Saharan Africa, especially in this area, highlighting Nigeria and Cameroon. So we had a patient that went to visit their homeland in Nigeria to bury their mother. They had lost their mother, but they were based in South Africa. So they left a non endemic malaria area, traveled to a malaria endemic area, and then went back to their home base in the non endemic malaria area. And this is kind of what I've just said now. The patient was a otherwise healthy male who presented with severe malaise, headache, althalgia, very ill and febrile. He went to the emergency room when he got back from South Africa about 7 days after returning, and the symptoms were persistent since he came back from Nigeria. And when he went to the ED, the physicians consulted him, did the physical exam, and they decided to administer a malaria RDT, which is the rapid diagnosis test, and a COVID test, which we also know that those can be rapid as well. So, case progression, how did this go? So, first, they received a negative COVID and negative malaria RDT. And then, based on that, they decided to treat his symptoms, which did look flu like, with IV Tylenol to reduce the fever. And they sent him home with Lornoxicam, 8 milligrams, one tablet every 12 hours. So, how did that continue to go? The patient's condition continued to deteriorate. He was not doing any better. And that led to him reaching out to one of his family friends that are based in Europe, who's also a family practice doctor in Nigeria, who, based on the signs and symptoms that he explained that he had, he didn't really agree with the negative RDT, and he ended up prescribing him anti-malarial medication. And lo and behold, then he started having symptom resolution. So, what exactly was he prescribed? He was prescribed chloroquine. This is a medication that I take very often when I travel back home. I'm sure a lot of people that have traveled to malaria endemic areas take this. You're advised to take it about 1 to 2 weeks prior to travel, take it while you're there, and also continue to take it when you return because malaria does have that incubation period that you want to make sure you cover for. This, I'm not sure if you guys are able to see this picture well, but while I was back in Cameroon, this is actually the manuscript that I was using when I was working in the lab to take people's blood smears, fix them, stain them, and look at the parasites. So this is literally a booklet in which we use to diagnose malaria. This is just some steps in which you do. You take the blood sample, you air dry it and fix it with methanol for 10 minutes. Then you put the Giemsa-Stained on it, you let it sit for a little bit, you wash that off with some water, and you put some to remove any of the excess, you let it air dry again, and then you're finally able to look at it under the microscope. And these are actual pictures that I took of some patients that were malaria positive. Unfortunately, you may not be able to appreciate it too well because it is a photograph and I had to zoom it in. But when I was looking under the microscope, you could literally see some of the parasites in the red blood cells. So this is literally what is done at most times, like the gold standard, in order to see the stage in which the parasites are infecting the erythrocytes. This is the lab setup. I was working in Dr. Ndifo's clinic in Limbe, Cameroon. That's where my family is based. And this is the serology lab. I was working with the medical technologist a little bit just so I can get exposure to how they diagnose malaria here. As you can see, the microscopes. These are the gym sustaining products in the back. This is just your nitty gritty, nice lab setup. You don't need too much, but you can have enough to be able to properly treat people. So, after this is all said and done, what is the real reason and why I decided to present this? The majority is this patient in this case report was based, like I said, in the non-endemic malaria area. They traveled to endemic area and came back to their home base. And they were improperly diagnosed by healthcare providers in their home base, probably due to the fact of the wrong diagnosis test being used. But with that standing, it's very vital and important for healthcare providers that work in non-endemic malaria areas to be able to see the signs and symptoms and be able to diagnose this properly in order to reduce false diagnosis and have people going untreated with this disease. It's also good with things like COVID and the flu, especially a lot of people travel back home to Africa in this season. It's winter for us here, but back home it's dry season. So you may have people coming back with symptoms that look like COVID or the flu, but in fact, they might actually have malaria. So it's really important for us that are in the non endemic areas to know exactly how to diagnose and treat these patients. Just another snippet from the World Health Organization. They do endorse as the gold standard of the diagnosis, the Giemsa-Stained microscopy blood smear, in order so you can see the different stages of the parasites and so you can know exactly how much of the malaria load that you need to treat for. Sometimes you might need pills. I've had malaria load that was so heavy in me that I needed IV, like the pills were not enough, which is why the gold standard is that blood smear so you can see the exact burden that's in the body. And this also kind of exposes the limitations to the rapid diagnosis test because, as we know, with antigens, they need about 7 to 10 days, maybe more for some people, for you to show antigen positive on the test. So we also have to keep in mind the way these diagnosis tests that we're using, how they work, and how they show positive results so we can know when to use them. Just to highlight some of the rapid test limitations again, obviously there's false negatives depending on when you test. They are very helpful. Let's say if you are not in an area where you have access to a lab or you're not able to do the blood smear. So they're not all bad. They are helpful in a lot of cases, but usually you would do the rapid and then you would also still do the blood smear. That was what we practiced in the hospital back in Cameroon. We did the rapid test so we could start treatment as promptly as possible. But we did also do those blood smears in order to know exactly how much we're treating and how much of the plasmodium load that we're trying to treat for. And the major impact on healthcare providers that I hope we all, as student physicians and people in healthcare, can take from this is I'm going to keep harping again. Your primary care doctors, your ED physicians, your hospitalists, people that patients present to with acute care. I would really encourage them to be privy to the gold standard of diagnosis so that they know that option is available in order to ensure that their patients are being treated adequately. And also just for us to be mindful of the epidemiological changes that the world is experiencing. People are traveling more to places that they didn't have access to before. People were locked down from COVID, so now people are really wanting to travel. So just because you might live in an area that's non-endemic to a certain disease does not mean you will not see those cases present there with the migration and the traveling that's happening now more and more. These were my resources that I used. And thank you all for your attention. And I can answer any questions to the best of my ability if anyone has any.
Student Dr. Igwacho, that was amazing, excellent talk. I love the passion you brought to the table and the knowledge. Moreover, the experience you shared with us regarding the goings on in Cameroon and showing us the lab was just a superb touch. Congratulations again on such a fantastic presentation. By the
Thank
way,
you.
Dr. Wolf is here, and I believe he has a question for you.
Hi, Dr. Wolf.
Yeah, hi, thank you. I'll comment as well that I thought your presentation was excellent. I had two questions actually. So that the first relates to, the type of malaria that's actually there. You know, standing here, I can't think there's different strains. I mean, is your predominantly the main strain, the falciparum or whatever it is?
Yes, it is. That's predominantly the main strain, which ironically is actually one of the more aggressive strains. So not only is the most common, but it's the most aggressive. So it's just fortunate that in those endemic areas, they're able to treat it very, very promptly because if you have some of those more common strains that are actually more aggressive in non-endemic areas, it might not be the best, especially if they go untreated for a while.
The next question that I had related to chloroquine resistance. Are you seeing much of that there?
I haven't seen much of that. Now I whenever I am back home, I do see a lot of patients that come in with malaria and typhoid fever at the same time. So they're taking like both drugs to treat them. I really do not see a resistance. Also, on the term of pharmacology, it's not like America where you need like a prescription to get the drugs. So a lot of the times if people start having joint pains, there's been times where I was running a fever and my dad just went and got me the meds from the pharmacy because you don't need a prescription or anything like that, especially when the disease is so common. People know the different type of drugs to use. So I personally haven't seen resistance, but that would be something I would be interested in doing more research into seeing, considering its use so often.
And then my last question is, what kind of impact has the Bill and Melinda Gates Foundation had? I thought malaria was a major focus of them, and I'm wondering if you're seeing any impact on the ground.
The major impact I've seen is the more availability of the rapid diagnostic test. But however, I did have a question to the physician that I was working with because I know that if I've had malaria and I have it again, I kind of already have those antigens. So I was kind of curious as to how useful those are in the endemic areas where if I had malaria a month ago, I'm probably going to still have those antigens there. So I'm going to test positive regardless. So that was my major curiosity even with like some of the COVID testings that we had, we were getting like the expired ones, that were sent from like Europe and China. So a lot of the times, on the outside, it seems like a lot of resources are being sent back home. But if you're not able to actually be on the ground and see how they're being used, you won't really know exactly the exact type of resources that they're receiving. So that's a really good question. I'll definitely keep my eye out and ask some of the physicians if they're noticing any more of an impact from that.
All right. Thank you very much.
Thank you too.
Student Dr. Igwacho, congratulations again on such an amazing presentation. I see a very bright future for you moving forward. You did a
Thank you so
fantastic
much.
job. Oh, Dr. Talley, go ahead.
Hi, I am so glad you're doing this work. And I just wanted to ask you, I know Carol MacArthur has been working in Congo and also Cameroon. And she received an award from the World Health Organization on her work with malaria.
Oh, wow.
And she is located here in Kansas City, Missouri.
Oh, wow.
Yes, and so I was wondering now, I know she's got a big contract with Abbott now. Oh, and she's working in Congo on the mechanism for the changing of the HIV virus. And I don't, she has taken our students in the past. So I'm just wondering, yeah, if
I would That sounds very interesting. I would really love to be a part of that. That
okay.
sounds really nice.
Now, where are you located? Are you in Joplin or Kansas City?
So I was originally in Joplin, but I'm doing my clerkships in Florida.
Okay, so you're in your third year?
Yes, yes, ma'am.
Okay. Um, if nothing else, you can have some conversations and figure out how you can enhance each other.
And I don't think that location would be too much of a factor, because, that's, my, kind of home base. That's where my parents are. So I think if you have the passion for something and you have the quest for the knowledge and want to see an impact and change in something, location is really nothing to be worried about. We have Zoom and we have planes, and I would definitely love to pick her brain and learn more about what she's doing and how I can add to that.
Okay, that's great. She is the same kind of person that a plane isn't a barrier. So
Yeah,
she's from New Zealand. She went to UMKC School of Medicine, graduated from there, did her residencies. She goes back to New Zealand frequently because she has research there as well.
wow.
So yeah, so you and she have a very interesting perspective, which
Okay.
I think is wonderful. What is your home country?
Cameroon.
Okay. Um, all right. Would you mind if I got in touch with her?
I was gonna ask you if I could take her email, or what would be the best way, if you already have a relationship with her and you don't
Yeah,
mind, just at least, I can put my email in the chat here. That way at least you can just introduce us. So she kind of,
yeah.
and that I would really, really appreciate that.
And let's see. There is no chat. Oh, okay. Okay, so all right.
So just to finalize here, again, I just wanted to say it was extraordinary job. I did have one question as you were talking here, and that was, why isn't the Giemsa-Stained? I mean, that struck me as being so easy. Why do they do the rapid diagnostic test when that Giemsa-Stained seems so easy?
Um, from my personal experience, when I've been very, very sick with malaria, I think they do the rapid test, number one, just because when I was diagnosed, the two times I had to be hospitalized, we s- it takes a little bit of time because they have to draw the blood, they have to, centrifuge it. But when you do the rapid test, they literally can send someone to the pharmacy to start getting that, because they do the IV drugs based on your body weight. and based on like the load. So they started me on IV medication before my blood smear came back. And then when my blood smear came back and they knew exactly how much it was, they just upped the meds. But I think the rapid test is pretty good to at least know, okay, you can see someone is super, super sick. If they have it, let's, start them on IV, because there's IV and there's pills. So obviously when you have a load that's pretty high, the pills are not really going to do much for you. So I think that might be the reason, which is why it's a really good tool to use, but I probably wouldn't just use that as my only one, especially if the symptoms do look that way. I would still probably encourage people, if they have the opportunity, to get a blood smear.
Do you think the rapid test was performed incorrectly on your case?
I think it was. I think it was performed incorrectly, and I personally think, from talking to the patient, that the doctor kind of already thought it was COVID, and they were trying to just rule out COVID and just did the malaria test because maybe they had traveled to Nigeria, because they were really focused on the flu and COVID. Because even when those tests came back, they still treated them for the flu, and which we do have flu testing. You can see if someone has influenza A or B, which they didn't do, which is also interesting because in hospitals here, they can know if you have influenza A or B. So they just kind of treated them based on, okay, it's not COVID, and the malaria was negative, so it has to be the flu. Which that was really my point in trying to get people to see, not to just like anchor in on something, especially on the notion that, oh, people don't really have it here.
Good. Thank you. Excellent, excellent talk. Wish you well.
Thank you so much. Thank you guys for watching. I don't know if I just like leave or not.
Yeah, I think you can leave, and I'm going to end it here for Dr. Staudinger, who had